hello again. I'm Marie McCary, and I work at the Care Inspectorate, and we're really pleased that so many of you have been able to come along today to listen to all our great speakers. Jackie, my colleague who's also on the call, likes to call them IPC royalty. So thank you very much for coming along. To listen to the discussion and join in and make the best of the resource that we've got to look at keeping antibiotics working for everybody and how that's everybody's business. So next slide, please, Jenny, and I'll give you some housekeeping just before we get started. So we're expecting the webinar to run for approximately an hour and a half, and you'll maybe have noticed that we're recording this, and that's so that we can provide it for you when we're finished, and we'll do that after the webinar. There's some microphones and cameras have been switched off, as you've probably realised, and we're doing that really just to try to make sure we don't lose contact with you. But please use the chat function to ask questions, and there'll be time for questions and answers at the end of the session. We've already had some questions received, and we'll use those. We've got a couple of interactive polls that we'll do as we're going along, so that we can gather your opinions and views and thoughts, and we'll make the slides and the recordings available to you by email after the webinar. So the first thing that I wanted to mention to you is that Jenny, who's on the call, and I'll introduce her in a wee second or two, will be using polls, and she'll launch the polls when we reach them and give us some time to gather thoughts and to think about that. Because there's a number of you on the call, there's 129 of you at the moment, we sometimes experience a bit of a problem with the sound quality, and if you have any sound issues, make sure you've put the volume up on your device. I know that sounds a wee bit basic, but sometimes that can be the problem. And just to remind you that this is your session and it's an informal session, so make sure you have a cuppa, and again use the chat function to ask any questions and participate as much as you can. Next slide, please, Jenny. So I want to tell you a wee bit about the aims of the webinar and who the webinar's aimed at. We're aiming at all staff who work in adult social care, and we want to raise awareness about antimicrobial resistance and antimicrobial stewardship across adult social care, including care homes, care at home, and amongst the staff groups. And we want to provide you with an opportunity to explore what antimicrobial resistance and antimicrobial stewardship are and what they might mean to you in practice. And we'll do that through the question and answers towards the end of the session. We've got a couple of learning objectives, and they're about understanding what antimicrobial resistance is and how this occurs through antibiotic use and misuse, and to increase your understanding of antimicrobial stewardship and how this applies to you and your role, and to highlight the importance of multidisciplinary teamwork in the delivery of antimicrobial stewardship, as keeping antibiotics working is everybody's business, as the title suggests to you. So first of all, I want to introduce you to the team, and maybe the team will put their cameras on so that you can say hello. And first of all, to Jo McEwan, who's here. She's the lead antimicrobial stewardship nurse at NHS Tayside. And she was appointed as the first antimicrobial stewardship nurse in the UK in 2013. So Jo has been in the business of nursing and has nursing experience over a 20-year period. She's very experienced in infectious diseases, infection prevention and control, and health protection. And she's also held a number of leadership positions. As part of her current role, she holds a senior clinical teaching role at the University of Dundee, and Jo founded and chairs the Scottish Antimicrobial Nursing Group. So hello Jo, it's great to have you with us. And also Jo's colleague, David Shepherd, who's a registered nurse. And since 2012, David has also worked within the Infectious Diseases Unit, Infection Prevention and Control in Tayside. And in August 2024, just last year, he took up the position of Senior Antimicrobial Stewardship Nurse, with a focus on the role being about promoting optimal antimicrobial practice and supporting care homes and health and social care teams to raise awareness of AMS. So David's post's a bit unique, and it's the first, I think, of this type of post within the UK. And Sabine Nolte is with us also. So Sabine works for NHS Education Scotland, and she's worked in education since 1992, and she's been a principal educator in the IPC education team at NES since 2008. Sabine's got a background in education, project management and digital learning, and her special interests are e-learning, instructional design and impact evaluation of educational projects. She jointly manages the Cleanliness Champions programme that you'll all know about, and she was project lead for the development of the SIPSEPS, the Scottish Infection Prevention and Control Education Pathway. So she now manages the learning resources for antimicrobial resistance and antimicrobial stewardship, and she's developing a knowledge and skills framework on containing and controlling antimicrobial use and antimicrobial resistance. And that will be designed for health and social care in Scotland in collaboration with the Scottish Antimicrobial Prescribing Group, SAPG. We're also joined in the call by Jenny Ross, who's our Marvellous Improvement Support Officer, and she's the person in the background doing all the things that we need to keep us on track and to move on the slides, and she'll do the polls also. And she'll make sure everything's working and that we're moving along at a speed. And Jackie Dennis, who's our Senior Improvement Advisor here at the Care Inspectorate, with a focus of her work being on IPC generally. Jackie will be watching the chat and pulling together any questions that come in from you, and we'll look at those with our expert panel later. So next slide, please, Jenny. When you hear from Jo and David and Sabine, I want you to try and keep in mind the SIPSEPS and the programme because of the good practice documents that are readily available, and these can help you with your practice in helping to reduce the need for antimicrobials. So what I'm getting at is there's a lot of information out there, and there's a lot of good practice documents that are already in use. So keeping that in mind within the roles that you have, and how that might influence you to keep antibiotics working as part of good IPC practice. And as you know, within our own quality improvement frameworks, we use core assurances so that we look at IPC issues when we come out to services, and we also remind staff about the SSSC's codes of practice, because they reflect your responsibility. For example, within our quality frameworks, there's the IPC core assurances. And we use these as part of our inspection, and they come from the IPC standards that I noticed are on a slide that's coming up later. So all staff need to be trained in and can demonstrate that they understand and apply the principles of infection prevention and control in line with their role, that there's a nominated lead person who has responsibility for infection prevention and control, that the service has governance and quality assurance processes in place about infection prevention and control, that leaders ensure that staff have access to suitable equipment and appropriate cleaning products, and that there's a robust risk assessment undertaken and approved through local governance if any of the IPC standards can't be implemented for any reason. And also, if you were to consider your SSSC codes of practice, in particular, I'd draw your attention to 3.1. I must promote the well-being and independence of individuals and carers while protecting them as far as possible from harm. And code 3.2, follow practices, procedures and policies designed to keep me and other people safe at work. Similarly, 5.1, must be accountable for the quality of my work and take responsibility for maintaining and improving my knowledge and skills. Meet relevant standards of practice and work in a lawful, safe and effective way. And 5.6, maintaining my continuous professional learning to develop my knowledge and skills and contribute to the learning and development of others. So those are the kind of key things that we wanted to draw your attention to in terms of good practice and why it's everybody's role to keep antibiotics working. So before we move into the main session, we've got a couple of questions for you we'd like to ask you, and Jenny will help with the launch of the first two polls. So poll 1 is about how much knowledge do you have about antimicrobial stewardship and antimicrobial resistance? And poll 2 is, do you think you have a role in antimicrobial stewardship? And you can answer those questions either in the chat or you can submit. So the first one, how much knowledge do you have? And you'll see that most people on the call today, 53% of you at the moment are saying that they've got some knowledge, and 26% are saying no knowledge, and good knowledge 18% and very good knowledge 2%. I think sometimes the language of antimicrobial stewardship and antimicrobial resistance sometimes puts people off or makes people think it's not maybe something for them, it's for other people to look at antimicrobial resistance or stewardship. And so that might be the reason that people are telling us that they've got no knowledge of these areas. So hopefully we'll be able to rectify some of that during the session today. I'd definitely like to be able to do that and at least get you to the point where you feel that you've got some knowledge and you know where to go if you're looking for more information. So that's an interesting one, I think. And the second one is, do you think you have a role in antimicrobial stewardship? I might have answered that a wee bit as we've gone along, and I suppose the title of the day today about it being everybody's business gives you an idea that we think that everybody's got a role in antimicrobial stewardship, even if it's just about making sure that a course of antibiotics are completed by people that experience care. So that's good that the vast majority of people, 89%, are of the same opinion and know that they've got some kind of role in antimicrobial stewardship. 2% are saying no, and again, we'll hopefully rectify that through the day, and a few of you, 9%, are not so sure. So thank you very much for completing the poll. I think that's of interest, and I hope it's of interest to you, and hopefully we'll be able to rectify some of that during the course of the afternoon. So without further ado, because I've talked too much, I think, I'd like to hand you over to Joe, David and Sabine, who'll be taking us through their presentations. So Joe, first of all, hello, welcome, it's great to see you. I've got to bow down to all your superior knowledge and your specialism, and we're hoping to learn a lot from today. So thanks for coming along, Joe.
Thanks for the lovely introductions, Barry, and thanks very much to the Care Inspectorate for inviting us along this afternoon. And it's great, I'll just echo what he's said already, it's great to see so many people on the call today. So if I could have next slide, please, Jenny. So the first section of this afternoon's presentation, I'm going to take you through some of the background around what antimicrobial stewardship is, antimicrobial resistance, and how that affects us not only as health and social care professionals, but also how that impacts us on a societal basis as well. So as we've already heard, everybody has a role to play in antimicrobial stewardship. But that's not just in our professional working daily lives, that's also within our personal lives as well, as we'll see as we go through the presentation. So this slide really demonstrates that it's not an easy fix. Antimicrobial stewardship isn't just a single intervention. It involves many, many different interventions that are delivered and supported by health and care workers across all health and care settings. So it doesn't matter what the environment is that care is being delivered in, every single person has a role to play. Next slide, please, Jenny. So I recognise that most of you on the call won't be prescribers, but I thought that to set the scene, some of this information might be of interest to you around antimicrobial prescribing facts. So in 2023, a third of people in Scotland received at least one antibiotic, and this was up 22% from 2020. So when we think about the population of Scotland and the volume of antibiotics that were prescribed in 2023 and consumed in 2023, that's quite a lot. So if that's not concerning, the evidence suggests that about 20 to 50% of those antibiotics are inappropriate. So inappropriate in terms of it might be the wrong antibiotic, the wrong drug to treat the infection, it might be prescribed at the wrong dose, prescribed for the wrong duration, and we've all seen instances where antibiotics are consumed or prescribed for just in case scenarios. And those are the ones that we really, really want to do away with. And when stewardship programmes were first introduced, they really focused on the hospital setting, and there wasn't much thought given to where the vast majority of antibiotics are consumed and prescribed. So the vast majority, so 80% of antibiotics are consumed within community settings, and most of these are for upper respiratory tract infections. And that's why we see over sort of seasonal variation, particularly around winter, where we see a rise in our antibiotic usage across all care settings. We often see antibiotics prescribed for self-limiting infections, so we know that antibiotics don't work against viruses, but there are also some bacterial infections that the body is very, very good at recovering from on their own accord without the need of antibiotics. So the inappropriate and excessive use of antibiotics, it comes at a real cost. So we see an increase in antimicrobial resistance development. We also see an increase in Clostridioides difficile infection, so C. diff infection with overuse of antibiotics. And where people acquire antimicrobial resistant infections or C. diff, we also see increased morbidity, increased mortality, so people die from these types of infections. And we see increased costs, not just to the healthcare providers, but also to the people, the carers, individual and cost at individual level. And particularly with our older adult population, where resolution has been achieved from an antimicrobial resistant infection or C. diff, people quite often have a reduced quality of life thereafter. So that in itself is a significant cost. Next slide, please, Jenny. So why is our role so important? So our role, routine professional practice, we as healthcare providers tend to be and tend to have regular review and engagement with the clients and the people that we care for. We are the point of contact for all these individuals. We are the consistent role at the point of care and people experiencing care, including patients, relatives and their families. It's often our role, as we spend most time with the people that we care for, to detect and identify an early recognition of the signs and symptoms of infection and communicate that to seniors or medical or prescribers within our practice. We also have the primary role as registered nurses to promptly and safely administer medications, and those working in supportive roles may have roles to prompt the use of medicines in a safe and effective way. We also have a responsibility and accountability, and as Marie alluded to earlier on, we all work to a code. And within those codes of conduct, we have a duty of care to do no harm. And harm isn't always visible. So supporting and promoting antimicrobial resistance in a person or within a community is harm. It doesn't always have to be visible. And as I mentioned, we have a duty of care to make sure that people receive the correct medications at the correct time. Antimicrobial stewardship was recently identified within the NMC standards of proficiency for both nurses and midwives as a key skill to have upon graduation. And under all codes, we have an obligation to keep our knowledge and skills up to date. So again, seeing so many of you on the call this afternoon, that is certainly music to my ears. Jenny, next slide, please. So what is our role? When people think about antimicrobial stewardship, they often think about the act of prescribing. So that pen to paper, and that is important. Getting the right drug for the right infection is crucial. But we often have a role either side of that, and I like to think of this as the antimicrobial stewardship sandwich. So as I mentioned earlier on, those of us that are working within health and social care, we spend the most time with the people that we work with, that we care for. We often identify people that were deteriorating. We often provide that initial assessment. We should be aware of appropriate use of diagnostic tools. So when to use which diagnostic tools, which algorithms, supporting guidelines could aid a diagnosis and a clinical assessment of the people that we're caring for. Knowing what the correct signs and symptoms of infection are and communicating this with a senior or our prescribers. And all of that information, if we get that right, allows the prescriber at the point of prescription to make the best decision around clinical diagnosis and perhaps decide around whether or not to prescribe an antibiotic and which antibiotic would be most suitable for the circumstances that we have shared. But our role doesn't stop there. So we have the aftercare element as well. So making sure that we are safely and effectively either administering or prompting the medicines. We have a role in watching for signs of clinical improvement, and that might include checking a person's vital signs as well. And whether or not there's improvement or deterioration, we have a role to communicate that to the wider team that is wrapped around that person's care. So irrespective of where we work, we have a role either side of that act of prescribing to support good antimicrobial stewardship and good decision making. Next slide, please. So why do I need to know this? Well, in 2022, the infection prevention control standards were revised, and standard 5 within this document relates to antimicrobial stewardship. And for the first time, this was a cornerstone in recognising the breadth of responsibility and remit around antimicrobial stewardship. And this was the first time where we've seen the scope of practice moving beyond the hospital setting, recognising that health and social care areas have a role and a responsibility around antimicrobial stewardship as well, so that we can ensure the best outcomes for the people that we care for across our health settings. So it's relevant for everybody, whether professionally or at home, because I'm quite sure many of you on the call will at some point in your life have had an antibiotic. If you haven't, you're very lucky. But that's not to say in the future you may not require an antibiotic. So we have a professional and a personal responsibility to take antibiotics responsibly. The infection prevention control standards emphasise that we need to promote awareness to all staff involved in prescribing, supplying and administering antimicrobials, enabling all staff involved in healthcare delivery to access the relevant education and training. Care Inspectorate, you could be asked during one of the visits about your level of knowledge around antimicrobial stewardship and infection prevention control. Just last year, the UK 5-year antimicrobial resistance strategy was launched by the UK government. And again, it was music to our ears within the infection community that the recognition of the role of all health and social care partnership areas was published within this document. So no longer is it a hospital responsibility to promote good antimicrobial stewardship. There is an expectation that all individuals working across and in health and social care have a role to play in training, education, and promoting and applying good antimicrobial stewardship to clinical practice. Next slide, please. So antimicrobials are a wonderful, wonderful drug. So by the term antimicrobials, I mean antibiotics. So all drugs that either kill or inhibit the growth of bacteria. They were first discovered in 1928 by a fellow Scot, Sir Alexander Fleming. And since their discovery, they have changed the way we deliver health. So our death rates associated with infectious diseases have reduced significantly since we discovered antibiotics, and our human life expectancy has increased significantly as well. So that's just in the treatment of infections. But antibiotics also have a supportive role to play in many, many health interventions that take place on a daily basis. So many complicated surgeries receive antibiotics to make sure that they are safe and effective and the outcomes for people are optimal. Critical care could not deliver what they deliver in today's standards if we didn't have the supportive use of antibiotics. Many people with organ transplants have a need to take lifelong antibiotics to support their well-being as they move forward. And also from a cancer chemotherapy perspective, many individuals receiving cancer chemotherapy rely heavily on antimicrobials supportively to optimise the outcomes of their therapy. Next slide, please. So what does the future hold? If we didn't have antibiotics, can you imagine a world where we didn't have antibiotics? What would our care look like? Would it surprise you if I mentioned that we could be looking at, in the future, the possibility of people with simple infections by today's standards being placed on palliative care packages and having supportive care packages wrapped around them because we don't have medicines or may not have medicines to treat simple infections? Routine operations that we take for granted by today's standards may have increased risks, so more people might die from such operations. We might not have the opportunity to use certain cancer chemotherapies. And even simple injuries like a scratch in the garden or a fall in the playground could pose a significant risk to someone's well-being. The World Health Organization identifies antimicrobial resistance as a major worldwide threat. And it's of such significance that the UN General Assembly, for the only time in history, have they discussed and held high-level meetings on a health matter on 2 separate occasions. There has been no other health indication that has warranted the UN General Assembly coming together on 2 separate occasions before. And that demonstrates how significant this is to health, but to society on a whole. Next slide, please, Jenny. So in 2016, the UK government asked Jim O'Neill, who is a World Health economist, to put together an economic impact report on how antimicrobial resistance would impact us at a global level. So the figures that they came out with and the projections that they came out with is that by 2050, so we're talking 25 years away, more people will die from antimicrobial resistant organism infections than cancer and diabetes combined. So the figure that they're putting on that is approximately 10 million people across the world will die every single year from antimicrobial resistant organism infections. So to simplify that, that would be one person every 3 seconds. That doesn't bear thinking about, and it's not that far away. Next slide, please. So why do we need antimicrobial stewardship? Well, since the discovery of penicillin, way back in 1928, from 1940s to late 80s, there was a flurry of discovery. So many antibiotics were discovered during this time period. So all of the antibiotics that we use today in modern healthcare delivery were discovered within that time period. But since about 1989, there have been no new discovery of antibiotics. So essentially, what we have available to us today in the chemist, within our drug cupboards, is all we have available to us for now and for the foreseeable future. Next slide, please. And when we think about antimicrobial stewardship, quite often the response that we're faced with is, why don't we just make a new antibiotic? But that's not the answer either. Because what we see from this timeline, so on the top of this graph, we see when the antibiotics were first brought to market, so they were first available for healthcare providers to use. And on the bottom line, we see when resistance was first identified. And for the vast majority of antibiotics, within a very short period of time, the bacteria are learning to develop resistance to these antibiotics over a quick period of time. So it's not necessarily the only answer. There are initiatives in play to try and develop and inject some initiative into the development of new antibiotics, but it's not the only answer. It's one solution, but we need multiple solutions together to make our efforts more effective. Next slide, please. So antimicrobial resistance, we've already heard that it's caused by the overuse and the misuse of antibiotics. And where we see antimicrobial resistance, it limits the effectiveness of antibiotics. So it makes infections very difficult to treat. So to put that in very simple terms, when we take an antibiotic, the antibiotic either kills the bacteria or it puts the bacteria into a very deep sleep. Now, I'm quite sure if I was going to attempt to try and kill any one of you, your first response is going to be fight back. Or I would hope your first response would be to fight back. And that's exactly what the bacteria are doing. It is survival of the fittest. So they are trying to find a way to navigate through an antibiotic-rich environment so that they can continue to survive. So I'm quite sure you've seen and cared for many people who have some type of resistant organism. I'm sure you have all cared for someone who has methicillin-resistant Staphylococcus aureus, so MRSA, and don't worry, you're not going to be tested on how to spell or pronounce any of these. Vancomycin-resistant Enterococcus, and I'm quite sure you will have cared for people with ESBL, so extended spectrum beta-lactamase producers. And these are just different types of resistance that we see within the bacterial world. One that is not so common just now is carbapenemase producing Enterobacterialis. Although it's not as common just now within the UK, that's not to say in the future that is not going to be problematic. And that is one of the pathogens or mechanisms of resistance that at a national level we have a major focus on and a concern around. Next slide, please. So antimicrobial stewardship, what do we aim to do? Well, essentially, we want to make sure that we optimise the safety of the people that we care for. We want to improve their outcomes, control costs to a certain extent, and we want to reduce the development of resistance, C. diff, and any toxicity that the individual may experience from the medicines that we are using. Because some antibiotics are quite potent and can affect people's kidneys and liver and other areas within the system. So putting it in its simplest form, it's making sure that we get the right antibiotic for the right person at the right time, with the right dose and the right route, and causing the least amount of harm to that person and future people and within our society. NICE guideline defined antimicrobial stewardship as an organisational or healthcare system-wide approach to promoting and monitoring judicious, so good use of antibiotics to preserve their future effectiveness. So we want to make sure that we use antibiotics when they're absolutely only necessary. We don't want to see antibiotics used just in case, because we are then giving the bacteria the opportunity to develop resistance mechanisms to that antibiotic. Next slide, please. So nationally, we've already heard that we have our 5-year National Action Plan, which is confronting antimicrobial resistance 2024 to 2029. So as a UK government and as the UK nation, we look and plan our initiatives a 5-year period at time. At the publication of our last 5-year action plan, 2019 to 2024, the UK government also published the 20-year vision, contained and controlled. So this demonstrates two things: antimicrobial stewardship and response to antimicrobial resistance development threat isn't something that we are going to resolve overnight. So by publishing a 20-year vision demonstrates to us within the health and social care field that the UK government are committed to tackling antimicrobial resistance now and in the future. This is a marathon, it is not a sprint. And every single thing that we can do collectively will help address the antimicrobial resistance agenda. So within Scotland, we have a number of organisations that support the implementation and the delivery of the antimicrobial resistance and stewardship agenda. So the Scottish Antimicrobial Prescribing Group, they have a responsibility from an antimicrobial stewardship perspective. And they work with health boards and antimicrobial management teams within the health boards to deliver safe and effective antimicrobial use. RHI Scotland are responsible for infection prevention control and antimicrobial resistance and healthcare associated infection elements. And the work of RHI and SAPG is supported in the delivery through the Care Inspectorate and Scottish Care. Next slide, please. So my final slide, I'm going to leave you with the One Health concept. So again, Scotland were at the forefront of antimicrobial stewardship and how this impacts not just humans, but antibiotics are often used in many other areas within our human food chain, within animal husbandry, and within our environment. And we all impact on the other. So when it comes to things like how we dispose of antibiotics, making sure that we don't dispose any leftover antibiotics, not that we should have any leftover antibiotics if we're completing the course, but making sure that we're not disposing these down our waste systems, so in our water systems, because that can impact our sea life and our water life in our rivers and our seas. Human food, making sure that most responsible food producers are now highlighting and demonstrating that their meat and their produce is coming from antibiotic-free environments. Animal health, again, a lot is being conducted around animal health in terms of reducing the use of antibiotics within our animal companion animals, our animal husbandry animals as well. And the same goes to say with our crops, with our land, making sure that we're not using antimicrobials in our pesticides, and to avoid using sprays in to avoid disease in the crops and land as well. So everything is interconnected. So what happens in the environment, what happens in animals, impacts us as humans and vice versa. So next slide, please, and I will pass you over to my colleague, David.
Thank you, Jo. Hello, David.
Hello. So I will go through this process of continuing on what Jo has been saying from a sort of infection control point of view, but how it relates to antimicrobial stewardship. So essentially, we know that infections are a persistent challenge in social care settings and care home settings as well, where residents are normally more vulnerable and due to their age, underlying health conditions, and close living quarters. This is why infection prevention and control is critical at stopping these infections before they start. By using this, we can limit antibiotic use and slow down resistance. So I will show you how it all connects and how everybody has a role in protecting residents and future generations from antibiotic resistant infections. So what are standard infection control precautions, or SIPs, if you will? Well, they're the basic measures that we take to prevent the spread of infections in healthcare settings and beyond. These precautions are designed to protect both healthcare workers and residents from harmful microorganisms, bacteria and viruses that can cause disease. At their core, the infection prevention control precautions focus on breaking the chain of infection, which means stopping germs from spreading from one person to another. And this is done by controlling how infections enter and leave the body, reducing exposure to infectious materials and maintaining a clean environment. These precautions are important because many infections spread through direct contact, the air, or contaminated surfaces. By following simple, evidence-backed steps, we can greatly reduce the risk of outbreaks from happening and antimicrobial resistance from taking hold. We're going to explore some key elements of these precautions in detail later on, looking at why they matter and how they are applied in real-world situations. Understanding and practicing these precautions isn't just for healthcare workers. It's something everyone can benefit from in daily life. Next slide, please. So the slippery slope of infection prevention control. So let's have a look at what happens when we don't follow these precautions as we should. So imagine a care home where infection control measures are ignored. So what do you think would happen? Let's say that someone wears gloves inappropriately or reuses them for another resident or has poor hand hygiene. This basically leads to a possible increase in transmission of harmful organisms. As we are dealing with more frail individuals, we're looking at the perfect sort of environment in care homes and social care places that will allow germs to basically spread unchecked. This causes an increase in infections within these settings, and since most care home residents are often elderly or have weaker immune systems, even minor infections can become serious, requiring medical attention and hospitalisation. This in turn leads to an increased use of antibiotics. So when infections rise, the doctors prescribe antibiotics more frequently to try and control the infections. While they are important for treating bacterial infections, as Drew has said earlier on, they are sometimes used unnecessarily, especially in illnesses caused by a virus, which antibiotics don't treat. So here's the real danger. As you heard Joe go on about it earlier on, Antimicrobial resistance is one of the biggest global health threats we face today. And as you can see by this diagram, there's a continuous cycle, and we're going down a further step each time that resistance increases in. So what is the solution? Well, it's strong prevention measures. This is the slippery slope we want to avoid, basically, where the best way to protect both residents and the effectiveness of antibiotics is through strong infection prevention control practices. If we consistently follow these SIPs, like proper hand hygiene, cleaning, and PPE, we can break this cycle. So to basically go in how infection prevention control and antimicrobial stewardship go hand in hand, I'll explain in the next slide. So next slide, please. So we work infection prevention control and antimicrobial stewardship. They work in tandem, essentially. So there are complementary strategies that work together to combat the spread of infections and reduce the development of antimicrobial resistance. To put it in a sort of good analogy, at the end of the day, think of infection prevention control and antimicrobial stewardship being on the same team as such, where infection control are like the defenders, making sure that they block any sort of infections from happening, and antimicrobial stewardship being more on the forefront of attack by using appropriate antibiotics and hitting significantly where it's needed to be hit hardest. So there is a lot of commonalities involved in both these sort of team strategies, but they are quite different in the way that they effectively work at reducing antimicrobial resistance. Next slide, please. So the standard infection prevention control precautions that are vital to antimicrobial stewardship, these are very much the forefront of everything to stop resistance from happening. So, for instance, good respiratory and cough hygiene stops the transmission of potential viral infections from happening, such as flu and COVID, for instance. If we have safe management of linen as well, we're looking at the fact that there should be proper storage, washing, and disposal of contaminated linen reduces infections from happening as well. So there's quite a few here, but I'm going to touch upon 3 of the main ones that I would say are certainly vitally important and the easiest to use in daily practice and care. So next slide, please. So effective hand hygiene, I would say, is the simplest and most effective way to stop pathogens from spreading from in care homes and social care settings, especially where elderly and vulnerable residents are at higher risk of illness. So looking at the WHO moment of hand hygiene, especially in residential home settings, we're looking at the 4 main areas before interacting with a resident, before any clean or aseptic procedures, after any body or fluid exposure, and after touching a resident. But this isn't just for aiming at care home. This isn't just aimed at sort of the care home setting. This can be used in all social care settings. For instance, what we actually touch in the environment, that when we go into people's houses, in homes and in day centres. So to ensure effective hand washing, we should follow the bare below the elbows rule. So no wrist watches, pedometers or bracelets, plain wedding bands, and no long sleeves or cardigans, making sure that hands and arms are clear to allow effective disinfection of hands within washing. So soap and water should be used instead of hand rub when dealing with any resident or client that has any diarrheal or vomiting illness where your hands are visibly soiled or dirty or may have been directly exposed to any sort of blood or body fluid, and certainly before serving any food. We've got to think about the fact that through contact, we're more likely to spread any sort of pathogens within these settings because we use our hands more than anything else. So next slide, please. So another element is looking at resident placement. So I'm very much aware of the complications that can be involved with resident placement and possibly isolation within care homes and social care settings. But we've got to think about if they have any sort of potential or if they have a definitive infectious status, we should be basing where they're placed on their infection risk and to minimize that risk of transmission to others. So one of the key considerations for resident placement are what type of infection is it? Is it bacterial, viral, fungal? How is this organism transmitted? Is it through the air? Is it from contact? Is it airborne? So for instance, if I use certain organisms for contact or skin to skin or contaminated surfaces, we've got MRSA or norovirus. That's done by contact transmission. Droplet, so that's through coughing or sneezing. That can be flu, COVID, normally respiratory illnesses, and airborne. So those are tiny particles that sort of linger in the air. So for certain organisms, there is like tuberculosis or chicken pox in the first instance. Those are considered airborne. So we've got to make sure that we have the appropriate resident placement in regards for those. And we've also got to assess the resident's ability to comply with infection control procedures. Now, we've got to think about, is the resident able to wash their hands, wear a mask, or stay in isolation if required? Fully realise that there is cognitive or physical impairments which may make it harder for some residents to follow these sorts of rules and increasing the risk of spreading infections, but to put the best mitigations possible in place in regards to it. Next slide, please. So clean environment is also another standard infection control precaution that is essential. So making sure that the environment is clean and properly disinfectant is essential to stop any sort of infections being transmitted from surfaces. For instance, like I touched upon earlier, MRSA, which is a resistant organism, can be transferred through contact. So if we're looking at sort of general cleaning of the environment, we would be using a detergent-based cleaner in regards to it. But for residents with known or suspected organisms or cleaning up fecal, urine or vomit contamination, we're looking at 1,000 parts per million of a chlorine-based cleaner. For instance, Titan Chlor or Actichlor in those respects. These sort of chlorine solutions should be dated and timed and identified for general use, or if they have higher concentrations for blood or body spillages. For instance, blood, it would be 10,000 parts per million. We make sure that that's labeled for those sort of fluid-based those fluid-based issues. So routine cleaning as well comes into this. So we know that the National Infection Prevention and Control Manual for care homes has a sort of guideline and gives links to the specifications for care homes in regards to making sure that the environment is clean to a certain standard in regards to everything. We also got to remember that if an outbreak potentially happens, we've got to step up our decontamination and cleaning efforts in order to prevent any sort of extra exposure to other residents in regards to it. Next slide, please. So moving on to PPE. So PPE should be used at the point of care. It should be changed immediately after each patient, after each resident, and or following the completion of procedure or task. For instance, it should be disposed of after getting rid of the bedpan or disposing of the fluid within it. Just to remember that aprons and gloves are single use. In regards to residents, that each resident should, considering that gloves and aprons are used going into these circumstances, they should be disposed of immediately before seeing another resident completely. Looking at the order of putting on PPE, now this is a silly question that I have basically, how could I put it? The order of putting on PPE, apron or gown, mask first, eye protection where required, and gloves is the way that we should be putting it on. But taking it off should be gloves first, apron, eye protection if worn, and then mask. So this is basically the order of taking it off minimizes any chance of spreading any potential organisms involved in regards to this. Next slide, please. So what does antimicrobial stewardship look like in practice? So within my role, as Joe has sort of said earlier on, 80% of antibiotic prescriptions occur in primary care settings. For example, GP practices, community clinics, and care homes. And nurse-led antimicrobial stewardship initiatives have been limited. Historically, as Joe mentioned earlier on as well, most of the stewardship efforts have been focused on hospitals, leaving primary care as uncharted territory for most nurse-led interventions. Within my role, I set out to engage as many primary care settings and care staff as possible to educate on AMS, and responses that I've noted is that most people embrace antimicrobial stewardship, many people not knowing what it is and how it affects them and others. Being within this role, created a lot of resources, providing education sessions and going out face to face to meet people, and has had a significant effect on the practices within NHS Tayside, where I'm based. Next slide, please. The thing is, with the reflections on everything that's sort of happened to date, the way that I could put it is, imagine trying to cover 2,900 square miles with 100 care homes. It is almost impossible to do as a single person. And that's why antimicrobial stewardship requires teamwork and multidisciplinary efforts on all fronts, because no single person can tackle antibiotic resistance on their own. Instead, it needs a sort of coordinated effort from everyone in the healthcare system, from care home staff to even the policymakers at the end of the day. And despite all the best efforts of that one person can do, the challenge is simply just too big. So the need for collective responsibility is needing to be uptaken, and one simple change in the way that we practice, we could preserve these life-saving medications a little longer to make the best use of them. what I'm going to do is explain one of the most common issues that has been seen in regards to stewardship whilst I've been in post, and I have been focusing on it for the last few months. So people could hopefully take this way in their daily practice and daily care of people. And it basically relates to UTIs and the diagnostics in regards to it. So next slide, please. So why do the appropriate diagnostics matter? Well, it allows us to get targeted antibiotics for the organisms that are causing the infection. For instance, it also prevents overuse of broad-spectrum antibiotics, which kill many types of bacteria, and using them too often obviously contributes to resistance as a whole. So you're probably wondering why the diagnostics, I'm going on about diagnostics and essentially sampling to get the appropriate antibiotics, how it relates to your practice. Well, the next sort of thing that I'm going to talk about is obviously urinary tract infections and how they are one of the most overly diagnosed conditions, and they lead to unnecessary antibiotic prescriptions. And you being the sort of forefront, as Joe mentioned earlier on as well, probably deal with the change in symptoms of people. So next slide, please. So I'm going to go on about dropping the dipstick, if you will, and using that as a source to see if people have a urinary tract infection. So if you think about 50% of older adults and nearly up to 100% of people with catheters have bacteria living in the bladder, and it's causing them no harm. And this is known as an asymptomatic bacteria. When bacteria breaks down, they produce nitrites and sorry, my throat's a little dry, so just 2 seconds. So it basically produces nitrites and leukocytes as well. And we always tend to hear the term the dipstick lit up like a Christmas tree. But what does the sort of leukocytes nitrites mean? It's basically the essential breakdown of bacteria within the bladder. And as 50% of older adults over the age of 65 and 100%, nearly 100% of catheterized patients have bacteria living in the bladder, causing no harm. A dipstick is no way to sort of diagnose a urinary tract infection, and it should be more symptom-based and not just a simple dipstick of urine to diagnose a UTI. So the Scottish Antimicrobial Prescribing Group has a tool which abides with the national guidance in regards to it, and that can be found on satg.scot, and it has a good algorithm to follow in regards to the potential of urinary tract infections in regards to it. Next slide, please. So going along with the symptom-based approach, and this is referring to the SAPG guidance. So if a person has two more of these symptoms on the left-hand side, if they've had a raise of temperature, or they've got a new or worsening confusion or agitation, if they've got a new lower back pain, pain on passing urine, an urgency for passing urine, increased frequency, if there is a large amount of blood in urine, and if there is a new or worsening incontinence or altered behaviour from the person. That could suggest that a urinary tract infection is quite possible in these circumstances. For someone that has a catheter in place, only one of these symptoms really applies. So if they've got a temperature, if they've got a new lower back pain, or they've got a new onset or worsening pre-existing confusion or agitation. So The thing about this is, and I'll explain another aspect of this in the next slide. Next slide, please. People automatically assume that urine, if it has got any sort of pungent smell or if it is discolored for any reason, that is a sign of urinary tract infection. It's not in quite a few cases. So we could be looking at the fact that they may be a little bit dehydrated, yes, but not necessarily that it is a urine infection. We've also got to remember that certain foods can affect the way that it smells and looks as well. So asparagus can cause a strong smell and beetroot can turn urine red or pink. We've also got to remember that quite a lot of our clientele are also on medications that also change the colour of urine. For instance, senna, which is a laxative quite commonly given out, can make urine look red or brown, and ibuprofen can turn the colour of urine pink to a certain degree if they're on long-standing ibuprofen. So just by looking and smelling and people saying, I can smell the urinary tract infection, they obviously have it, is not a good way of diagnosing the way that they possibly have it. Next slide, please. So we're always looking at a person-centered approach on the signs and symptoms. So you got the generalized fever, slightly lower blood pressure than usual, a fast heartbeat, possibly a new confusion, and probably faster breathing as well as a sort of general reaction to an infection. But we've got to think what other symptoms could be contributing to it. So as I touched upon earlier on with the urinary aspect, if there's frequency, pain, and incontinence, it's quite possibly due to a urine infection. But if the client has a wound as well and there's a lot more exudate coming out of it, it's leaking a bit more, it's looking more red around the edges and it's swollen, that could be the possible sign of the infection as well. Respiratory, and coming from experience with people, when I've given education in the past, people have always said that whenever they've had to call someone in the past for out of hours or anything like that, and the person has been coughing a lot and it's quite clearly respiratory, they've asked for a urine sample as well. So if we're thinking that it's respiratory in regards to there's more mucus coming up, a change in the colour of it, and there's changes to the breathing pattern, it's more than likely due to a sort of respiratory infection. And as a wise man once said, the simplest answer is often the correct one. If we're thinking that we're not chasing zebras at the end of the day, we're chasing horses, as it's the most common, it's more than likely the most common and simplest explanation that is causing all these symptoms. So next slide, please. So another thing that we can look at is the duration of antibiotics. So most uncomplicated infections require 3 to 5 days maximum, and antibiotic therapy should have a certain duration. If it doesn't have any sort of finish date, you'd always seek guidance from a registered prescriber to review the medication. From past experience, we've had people who have been on, and I have noticed this when I've been out in the community, from what people have told me, that people have been on antibiotics for several weeks when there hasn't been a need to. It's just never had a stop date in regards to it. So just always be aware that most simple infections, if you will, should only be on the maximum of 3 to 5 days of antibiotics. Yeah, next slide, please. And always good care. So good care reduces any incidence of infection happening and the need for antibiotics to be prescribed. It's basically we've got to make sure that people are hydrated, that we give good pressure care, and promoting good bowel and bladder health. at the end of the day. And I know that each and every single one of the people on the call today are doing their utmost in regards to that, and I salute you wholeheartedly in regards to it. So, next slide, please. So that's basically what it can relate to in practice, and the sort of main takeaways from my part of the session have been that infection prevention control and antimicrobial stewardship work together to minimise infection risks. Hand hygiene and PPE prevent the spread of infections. Antibiotics should only be prescribed based on symptoms, and we can prevent infections through good basic care. And applying these principles daily, we create safer healthcare environments and protect the future of antibiotic effectiveness for us all. And thank you. That's my bit done. Thanks.
Thank you, David. That was really helpful and really interesting and useful for everybody, I think. Thank you, Joe. Sabine's next, I think. Hello, Sabine.
Thank you. This will be hard to follow. Recognizing the time, I'll try and speed things up a bit. So welcome. This is a presentation on a new knowledge and skills framework on antimicrobial resistance and stewardship. Next slide, please. So I have split this up into two different parts. The first part is about a new knowledge and skills framework, and the second part is about how you can learn more about antimicrobial resistance and stewardship after this introductory webinar. Next slide, please. So the presentation focuses on the role of education in safeguarding antimicrobials. And the World Health Organization states that the education of the health workforce is of crucial importance as they form the front line in safeguarding the effectiveness of antimicrobial medicines. But we're not just talking about the clinical healthcare workforce here. That can contribute to keeping antimicrobials working. All staff in health and social care need to work together and have the right knowledge and skills to safeguard antimicrobials. This is not just something for healthcare. Next slide, please. And the next slide, please. So recognising the importance of the education of the workforce, the Scottish Government has commissioned NHS Education for Scotland and the Scottish Antimicrobial Prescribing Group to develop an education framework for health and social care in Scotland. And we have developed this over the past year with a short life working group of subject matter experts, and a wide consultation among health and social care colleagues in Scotland was carried out last year in September. We're currently creating a final draft and expect the framework to be published in spring, early summer 2025. It was quite a challenging piece of work as it needs to be right for so many different staff groups in health and social care. Next slide, please. So who is this framework for, and is this framework for you? The framework covers very broad staff groups of staff and also students. Basically, those staff and students who will interact or already interact with those in care or the families and carers. You can be involved in direct care or also in a supporting role, for example, in a reception. Also included are laboratory staff, because laboratory results and reports are essential for the treatment and of infections. And another important role is played by staff in management roles, because you can influence and direct the provision of services. I'm not sure how many managers we have on the call. So if you're either of those, then the framework is for you. It's also important to mention here that this is not a setting-specific framework. The content is all generic and it applies to all care settings because we're all in this together. Next slide, please. So to illustrate this, here's just some examples of the different roles that are covered by the framework, showing the variety of activity, staff and care settings involved in the care for a person. All these people can be part of a care journey of a person. Just imagine somebody in a care home and who they interact with, and perhaps they need medical care, or they need maybe even hospital care or dental care for a while. So there's a whole range of people that they need to interact with. It's not a specialist framework. This is meant to show how everyone can contribute in their own role, and a separate specialist framework is currently being developed as well. Next slide, please. The framework aims to raise awareness of AMR and highlight that we need to work together, and collaboration is key. So, and there's different ways in which this framework can be used. So staff and students can find out what you need to know to help and contain and control AMR. Teams can use it to support decision making. Employers and recruiters looking for new staff can use the framework to assess skills and identify required behaviours. And also, important is educators can use it to create appropriate learning resources and training sessions, such as this, for example. Next slide, please. So what does the framework cover? We built this based on the care journey of somebody. And this all starts with knowing the basics, understanding antimicrobial resistance and stewardship. And this underpins the entire framework, so we find that in the middle. The second part covers the prevention of infection, which is key in the very first step, because if we don't have any infections, then we don't need to give antimicrobials. And this was included specifically to emphasize the relationship between IPC and controlling antimicrobial resistance. And the next part covers how to then diagnose and assess infections, and how to decide when an antibiotic is required. Initial treatment, we call this, and this is then followed by diagnostic stewardship. So this means taking samples, testing, and identifying which microorganism we're actually dealing with here. So once that's been identified, you can move over to domain 5, which is by far the largest part of the framework, and this covers then the treatment and management of those who have acquired an infection. So that's supplying, prescribing, administering, monitoring, reviewing, adjusting antimicrobials, and also safely disposing unused medication so that this does not harm the environment. And all this is underpinned in the background by communication, education, collaboration, and management. But it's important to emphasize that not all of this will apply to all staff. Next slide, please. So as just explained, there are 6 parts, and each part is divided into subparts. So that would be domains and subdomains, and then each of those has different topics, and inside of that are different knowledge, skills, and behaviour statements. And I have put just a little example here on the screen about recognising individuals and their families and carers who need support to complete a course of antimicrobial therapy. Next slide, please. So then we indicate how all these statements apply to different staff groups, because that differs depending on your role. And the staff groups are indicative, and it's best to discuss with your manager, as everybody's role, responsibilities, and tasks are different. Obviously, if you're not allowed to prescribe, then the prescribing part would not be for you. And if you're a prescriber, then these parts are definitely for you. This was quite difficult to develop because there isn't really any other framework out there like this. This is not a career development framework. It shows how everyone can contribute to the cause. Next slide, please. So when using this framework, there's really only sort of 3 simple steps that you need to do. The first step is you need to identify the staff group you belong to, or educators which target audience they would like to address. Then you look at which part of the care journey you're actually involved in. And then you zone in further and you develop a topic or an area where you think that you or your target audience could really make a difference in. And then you select that topic and you seek to further develop your skills, knowledge and skills. Next slide, please. So this is just an example. It's not been designed yet. We just put all these elements that I've just described together. So we've got a domain, which is the first one, foundations. Then there's a broad competency statement. It has to be broad because it needs to cover everybody. And then underneath, I have just put a couple of examples of statements about antimicrobial resistance and roles and responsibilities. For example, explain what antibiotics and other antimicrobials are and why they're important, or explain what AMR is and what causes it to develop, or recognize your own role and see how you can make a difference. Next slide, please. So here are just some key points to remember. It aims to outline what everyone can do, just to emphasize that not everything will be for all staff groups. You don't need to work through it from cover to cover. The framework is for health and social care. And when the framework comes out, discuss with your line manager and within your teams what you could do. If you do one thing and implement this, you will make a difference. You don't have to do everything, but if you do one thing and you do it right, then you will make a difference. We're all in this together because it affects us all. We're all affected by antimicrobial resistance. Next slide, please. So just to ask a bit for your help, in your different roles, when the framework comes out, it would be great if you could help to embed this and to provide feedback on it. So use it and raise awareness of it. Think how you can embed it in your organization. Encourage AMS learning where you can, speak to others, and provide feedback when it comes out, how it's been used and how it can be improved, because we're very keen to continuously improve it and make it better. Next slide, please. So just briefly, considering the time, where you can find some further learning. Next slide, please. And it's important to say that completing a mandatory learning module somewhere on LearnPro or Tours or some other platform that you might have, or watching a video or attending a webinar is not the end all, be all and end all. Communication is key. And sometimes learning is best done together. Or you could network with colleagues, you could shadow colleagues, you could get some hands-on experience, or if you maybe have some more advanced knowledge, you could attend a conference and learn from others. So that's really important. Next slide, please. We put just some resources together for those starting starting a learning journey. Keep antibiotics working, 5 key messages. There is a poster. There's also a really nice BBC video that explains what a world without antibiotics would look like. And there's also a resource that we have for raising awareness of antimicrobial stewardship for nurses and midwives. I expect many of you on the call will be nurses, so that is suitable for all registered nurses and midwives. And if you complete this on Tours Learn, you can get a certificate, which you can then upload to portfolios or use for revalidation. So that might be something useful. Next slide, please. This is just to show you what this poster looks like and what it explains. So what is AMR? Why does it matter? Who can help? How do you do this? And where can I get more information? Next slide, please. This is what the Raising Awareness resource looks on Tours Learn. Next slide, please. So this is basically a resource with a pre-reflection activity, a main resource, which is currently a document, and a post-reflection activity, which here is still locked because I've not completed the document, which I can self-certify. It's just to illustrate you what it looks like. Next slide, please. So again, where can you find further information? The National Infection Prevention Control Manual and the Care Home Manual are the key resources. And the Antimicrobial Prescribing Group has pulled some key resources together for care homes. Next slide, please. Again, they've got the poster and they've got some good practice recommendations to use with frail older people, and also an information leaflet for staff. Next slide, please. Again, where you can find further information is please check your local learning platform, whatever you might have, but there are two key national resources on Turas Learn, which is the IPC zone, and an antimicrobial resistance and stewardship zone, which is currently under development. Next slide, please. As already mentioned, the most important thing we can do is to prevent infections in the first place. And if you're not aware of the Scottish Infection Prevention and Control Education Pathway, which is also known as SIPSIP, please visit the Turas Learn Infection Prevention and Control Zone. You can find introductory learning resources there and also a specific module for each of the 10 SIPs. Next slide, please. We currently also have some resources on antibiotic management, but enlarged there for those prescribing, apart from the programme on raising awareness that I have already mentioned. And these will all be on the AMS zone to make it easier for staff to find learning resources all in one place. Next slide, please. So to finish off, what can you do? Because I think you are here because you do want to make a difference. So even before the framework comes out, there's a few things you can do to contribute to containing and controlling AMR. And based on the learning journey of a person that I explained that the framework is based on, you can prevent infections, follow SITs, you can promote vaccinations, you can recognise the signs of infections, you can administer antibiotics and monitor those receiving them, you can make sure that the antimicrobials are taken correctly, they're not forgotten, and they're not disposed of in the bin. They're not disposed of in the toilet or somewhere, they're disposed of safely. And last but not least, you can communicate, or you should communicate with colleagues and those you care for, and the families and carers. Thank you very much. Next slide, please. Thank you very much. And if you have any questions or comments on the framework, please feel free to send a message to hins.scot.nhs.uk. Thank you.
Thank you, Sabine.
Back to Marie.
Thank you so much. It's really interesting and worthwhile, I think. Lots of information, though, for people to absorb. So we will send out the slides and all the different links so that people have got it. Before we go to the questions and answers, we've got another couple of polls for you. So Jenny's just put them on the slide. We want to ask you another 2 questions, and this time we want to know, how much knowledge do you have about antimicrobial stewardship and antimicrobial resistance? And do you think you have a role in antimicrobial stewardship? So the same questions as the last time, but just to see if coming along today's made any difference to you, if you feel that it's improved your knowledge or given you an idea of where to get resources and who to contact if you've got any questions or any queries or concerns. Because I know it can be a tough one when there's different kind of people that you might want to talk to. So that's good to see that 65% of people think that they've got a good knowledge, and that there's 19% have got a very good knowledge. So that's an improvement in both of those. Some knowledge for 16%, and no one's leaving with no knowledge. So that's great news for us all. And the second question is about how much knowledge do you have? Do you think you have a role in antimicrobial stewardship? And it's just a straightforward yes, no, or not sure. Oh, great. So 100%. I think everybody's got a role to play, and it's good. It's good to have an inkling of what you might be able to do. Small steps, maybe, but it does make a difference. So that's great. Next slide, please. Jackie is going to come in on the call, I think, now. She's been monitoring what's happening in the chat line. We haven't got an awful lot of time left, and I don't want to keep people back because I know it's been quite a long session. But Jackie, over to you. Let's hear what's going on in the chat.
The chat has been fairly quiet, which I'm really surprised at. There's been a couple of one or two questions, and we've responded to them in the chat, but we did have a couple submitted before the session. And one of the questions was, the person's observed antibiotics being prescribed over the phone multiple times for the same person or not prescribed when really needed. Does the panel have any thoughts on how people get the right treatment if not being seen face to face, and how will follow-up for these types of prescribing be followed up for accountability, to especially in the digital world? Does anybody want to take that one?
It's a toughie.
Jo.
I'll take that tough question. That's a very, very good question. And the short answer is we don't have any solutions right now. But the long answer is that post-COVID, we're all working very differently. And we need to take steps nationally and locally to support clinicians in the new ways that we're working. So I don't think we will move away from likes of Teams calls, consultations over the phone, near me consultations. That's here to stay. So how do we make the systems that we had pre-COVID fit best and support the care delivery in the new digital era? So that is something that is being looked at a national level, and how we can promote that and improve outcomes for people in different ways of delivering consultations. So I know it's a bit of a politician's answer there, so I apologise.
Yeah.
But it is just to acknowledge that that is something that we have recognised and steps are being made.
Perfect.
Thank you, Jo.
There's also a question around how long should you wait to report or escalate that an antibiotic does not appear to be working? That sounds like how long's a piece of string, but again, back to yourselves, what would you suggest? Is there a figure, a number?
There's no definitive answer, and that's what happens when we come into infection world. When we look at a lot of the historic evidence around infection management, wasn't really evidence-based. But what I would say is if there's no or even if there's no improvement within 48 to 72 hours, it might be worth a conversation with the prescriber. But obviously within that time frame, if a person deteriorates, we would want to escalate that in a prompt manner, because we don't want someone deteriorating at all, and making sure that they can get the treatment that they need promptly. As David mentioned in his slide set, most courses of antibiotics only need 3 to 5 days of antibiotics. So we would expect a resolution within that time frame. So if a 5-day course and there's no resolution, things are just the same by day 3, day 4, that's the time to have that conversation with the prescriber and they will offer advice. But there's things like wounds and cellulitis. The appearance might not look improved, but clinically the person is improved even after the antibiotics are stopped. So it depends on the syndrome and the infection that we're discussing. But generally speaking, if there's no significant improvement within sort of 48 to 72 hours, having that conversation and prompt action if someone deteriorates.
Brilliant. And the final one that came in, is there going to be more AMS nurses like David available across all board areas? And if not, how do the rest of the country get their help and support in relation to AMR and AMS?
Sorry, I'll
Are you
monopolise that
blushing,
one
David?
as well. I would love there to be more antimicrobial stewardship nurses across Scotland and in other boards. Right now there's not. There are only 3 boards in Scotland that have an antimicrobial stewardship nurse, and that is NHS Tayside. We're lucky enough to have 2, NHS Grampian and NH Lothian. So for the other boards, all health boards have antimicrobial websites, so you might be able to find information there. You will all be linked with infection prevention control practitioners within your health and social care settings, so they might be able to offer some advice and support and be able to direct any queries that you might have as well. And as Sabine mentioned, there's lots of resources on TURAS as well that can support learning in practice.
Finally, there's a couple of wee things in the chat. One is around adapting IPC measures for mental health nursing. That's in there. I don't know if even after the session we can and maybe reply to that. But the other one is, can we allocate this and train health and social care nurses to be champions? AMS champions? I don't know. That might be one for Sabine.
Got it. Well, I might take that actually, Jackie, because one of the things that we've one of the things that we've developed in NHS Tayside is the role of the AMS liaison person. And we're currently piloting that within the Dundee Health and Social Care Partnership to build and raise awareness of antimicrobial stewardship, but also build capability and application of antimicrobial stewardship within specific teams. So teams that we have currently within our pilot we have care home representation, we have district nurse ANPs, we have care and treatment centre ANPs and COPD nurses. But as I say, we are piloting that. So absolutely, I think that is the way forward, that we have a good understanding across all health and social care settings, and that might be a way to maximise our opportunity within the health and social care sphere.
Brilliant. So the big flurry at the end there, it was all quiet all the way through, and then we've ended up with loads of questions at the end. So thank you for that. Marie, back to you.
Yeah, well, just really to thank everybody. I'm going to put the next slide on, Jenny, just because I think there's a QR code, isn't there? Yeah. So we'd like to hear your thoughts about the webinar, and there's a QR code here that will link you to our evaluation form. All your responses are anonymous, and we'd really thank you very much if you could feedback on that. I was also wondering, are we leaving that slide up, Jenny, or is there another slide with the SSSC's information? Let's move it on so that if people want that, they've got it. You'll get it anyway. But there's the SSSC's CPL capturing your learning, so you can log on to your My Learning app and create a reflective note about what you've learned in the webinar using the title of the webinar for your heading, and you can do all that yourself and you'll get a response from the SSSC, and it will be included in your My Learning log so that it's captured for you. You don't need to think about it in a year's time, it's all there. So that's a nice easy way to do it. So thank you so much to our guests, Jo, David and Sabine. It's been really helpful, and I think it's given lots of people food for thought about what their role, however small that might be, should be around about antimicrobial stewardship, and how we can all make a difference, even if it is in a small way and having a small impact, because it's a problem that's there and isn't going to go away unless we do something about it. So we really appreciate your input today. It's been great to hear from you all. Thank you very much. Thank you also to everybody that was able to attend today. It's been great that that the event's been so well supported, and we'll see you again soon. Thank you then. Bye-bye just now.